So Haddad and colleagues a couple of years ago have written a very comprehensive and good review on right ventricular function in the preoperative setting, and they have listed a number of causes for right ventricular failure: pressure overload, volume overload, acute ischemia and infarction, and then other reasons like tamponade, pericardial disease, etc. When we focus for a moment on right ventricular ischemia and infarction, then we know from a number of studies that isolated right ventricular function is not very frequent, whereas right ventricular involvement in inferior or infralateral infarction is relatively common. In the intraoperative setting, we are sometimes faced with right ventricular dysfunction because myocardial protection on cardiopulmonary bypass was difficult and not as good as we want to have it in general. Intracoronary error also may primarily affect the right side of the heart because of the location of the coronary ostium. And then it has also been shown that patients with chronic pressure overload may have an acute ischemia in a perioperative setting when additional pressure comes into the system of the right ventricle. Excuse me. So, right ventricular function is important, and of course also assessment of right ventricular function. TOE is a wonderful tool for assessing cardiac function in the operating room, and most of you will know the guidelines by the American Society of Echocardiography and the Society of Cardiovascular Anesthesiologists. And when you look here at the cross-sectional views that have been proposed by them, you will find approximately 9 or so views that are focusing on the left ventricle, but only a very limited number of views focusing or also focusing on the right ventricle. Here, the 4-chamber view on the mediasophageal level, then the inflow, outflow view on the same level, showing the right ventricle. Then on the transgastric level, the short axis view when you turn it to the right. And finally, the transgastric right ventricular inflow view. Another issue is segment model. For the left ventricle, we have a segment model with 17 segments that is commonly accepted and gives us a common language to describe when we find something abnormal, where exactly it is. For the right ventricle, we have a 3-segment model. Gore and Lillehay have published that many years ago, and it's been used in many studies since then. They describe the inflow tract or sinus, the apical trabecular part, and the outflow tract or conus. So, the question is a 3-segment model sufficient for describing pathologies of the right ventricle? One might argue that there's only one coronary artery for the right ventricle compared to 3 coronary arteries and many branches for the left. That's not quite true. It's a little true, but the left anterior descending coronary artery is providing coronary supply to the anteroseptal wall and to varying minor parts of the anterior right ventricular wall, and also they give blood supply to the moderator band artery. This may result in collateral flow to the right ventricle in case of right coronary artery occlusion. On the other hand, the right coronary artery is supplying all other parts of the right ventricle. Just one little aspect, the coronal artery may have a separodorsal origin in approximately 30% of subjects, so patient with a proximal right coronary occlusion, but separodorsal origin may have a norm contraction of the outflow tract in this situation. So it's not just the right coronary artery, it's primarily. Here, it's an image taken out of the guidelines for echocardiographic assessment of the right heart in adults. published last year by the American Society of Echocardiography. It shows that different parts and different branches of the right coronary artery are supplying the right ventricle, but also parts of the left anterior descending. And here you in the left bottom, you see that the moderator band artery comes from the LAD. Here another aspect, of course, perfusion depends on the dominance of the coronary distribution, and that's another aspect of importance. So the question is, are 4 TOE views sufficient for comprehensive assessment of the right ventricle? There's some data suggesting that that's not the case. A couple of years ago in anesthesiology, there was a case report describing perforation of the right ventricle that was not detected by TOE. Then there are several studies describing that the apical part of the left ventricle may have preserved function in patients with pulmonary embolism and right ventricular infarction, whereas other publications have described that it is compromised in patients with non-embolic pulmonary artery hypertension. And more cardiological issue, the apical segments are primarily involved in arrhythmogenic right ventricular dysplasia. So it's certainly important that we can do a comprehensive assessment of the right ventricle, similar to the comprehensive assessment of the left ventricle. When we got into the detailed imaging of the right ventricle, we had the impression that especially the apical part is not always very well imaged by the standard views. So we did a study. My colleague, friend, and research fellow Jorge Jasper was the main person doing that. We studied a number of additional cross-sectional views for assessment of the right heart, and now I will go into those 2 views that help in assessing right ventricular walls. These are the transgastric right ventricular short axis views on the basic level, going from the tricuspid valve to the pulmonary valve, and on the apical level. So here you see an image, an echo image, and a picture that was provided by HeartWorks. You see doesn't it work here? Oh, yes. So you see here the basal segments of the right ventricle, here the inferior, lateral, anterior part, then the septum, infraseptal, and anteroseptal part. And when you advance the probe towards the apex, and you have to turn the probe a little to the right to obtain these 2 views, then you have the apical segments, again, inferior, lateral, anterior, and septal segments. And for doing a comprehensive scientific assessment of imaging of the right ventricle, we used a 9-segment model, as already mentioned, with the different segments that are listed. The basal segments here on this level, and the apical segments here. And we hypothesized that the feasibility of the additional views is similar to that of the standard views. And then we also hypothesized that when we have this 9-segment model, that the additional views will help to obtain 8 or 9 segments in a patient when compared to the standard views alone. So we studied 60 consecutive cardiac surgery patients at the examination after the induction of anesthesia, together with the baseline TOE examination, and performed an offline analysis by 2 independent readers. Here you see the percentage of views obtained in these 60 patients in gray. These are the standard views, and here you see the 2 additional views that we're focusing at right now. What you can see is that these 2 additional views were obtained in nearly 100% of patients, similar as most of the standard views. And you see these numbers here are the seconds that we needed to obtain the view in a good quality, and you see that also was quite similar to the standard views. Imaging of the right ventricular apical segments in fact turned out to be the tricky part. Excuse me. When you see here the apical segments, the septal, anterior, lateral, and inferior segments, then you see that in black that the anterior and inferior segments were not imaged reliably by the standard views, whereas addition of the additional new views increased imaging to very close to 100%, to 90 to 100%. What was the reason that we could increase that? Well, it was the transgastric right ventricular apical short axis view that allowed to image all apical segments quite reliably. And consequently also imaging of 8 or 9 segments of the right ventricle was feasible by the standard views only in 30% of patients, whereas we could do so in all but 1 patients when we combined the standard views with the additional views. So I would like to conclude that the proposed additional views in fact improve imaging of right ventricular walls. We believe that 4 TOE views for assessment of the right ventricle are not sufficient, especially when you have situations when you cannot obtain one or the other view. Then additional views can be even more helpful. We also believe that a 3-segment model is insufficient for detailed topographic descriptions. However, whether a 9-segment model, as we have used for scientific purposes, is feasible in daily clinical practice, time will show. Thank you very much for your attention.
Thanks very much for a very elegant presentation. Do we have any questions? We've got a good few minutes for questions if anybody wants to ask something. So those of you here who are routinely intraoperatively assessing the heart, are you using these various views or not at the moment? Any TOE anaesthetists? Yes. Yes, sir.
I do use the views in assessing the right ventricle and use the transgastric views, but I must admit I haven't. You know, the terminology is that you're using is new to me because it's not really in the standard SCA views. So you know, the terminology you're using for the right ventricle in basal and apical is not. We haven't really been using that terminology, so that's interesting to see it.
Well, I think there are many places where colleagues have been using additional views for quite a long time. They have just not been evaluated from a scientific point of view. But this shows that many people, or everybody who's involved in cardiac surgery, realizes sometimes that it's difficult to assess the right heart by the published standard views, and that many people are searching for additional cross-sectional views that give a better view of some parts of the heart.
Any further questions or comments? Hi,
I agree with the other comments, and I think it is early about whether it'll be clinically useful, but I think it probably will be, because we don't really classify the RV that well, do we? And particularly post-op, when you're trying to work out why things aren't going right, you're only making very general comments about the RV. You might say a lot more about the LV, and it's just global comments, aren't they? Poor RV function. And I think having some sort of classification and focusing your mind should be helpful. I think I'll look forward to trying it out, and when I do look at patients post-op more often, looking at the RV, I think really good. I think it's clever.
Thanks. Any further comments or questions? Yes, sir.
What about the usefulness of those cross-sections for the assessment of the quality of a tricuspid repair and the identification of the scallops? The leaflet, sorry.
I'll have a second talk this afternoon, and I'll focus there on the right-sided valves.
Okay. Well, thank you very much indeed.
Thank you.